Good morning, everyone. Thank you very much for inviting me here. I wanted to thank Professor Raj and the organizing committee. What an impressive place and what an impressive room. I've been asked to talk about prevention of surgical site infection and periprosthetic joint infection. The conflict of interest that I will tell you that most of the things we do today, we don't know if there is enough evidence behind them to support. As Benjamin Franklin said, the best is an ounce of prevention. And in periprosthetic joint infection, that definitely applies. The goal is to try to prevent. But if you look at the definition of prevention as the act of stopping something, I would say that it's probably more important to prevent our patients from being exposed to these risks during their lifetime. But that's very difficult to do because our skin has about 1 million bacteria per square centimeter. And you only need 10 microbes to develop periprosthetic joint infection or surgical site infection. Each patient has a unique immune system. Each patient may be exposed to different risk factors, and bacteria act differently under different circumstances. So our goal is to try to prevent those in multiple steps and try to prevent the clinical outcome, which is infection. So what I will do over the next few minutes, I will try to share with you some of the strategies that are known to be effective in prevention of infection. We've developed a risk calculator. This was based on 280 different factors that we evaluated, and each of those factors were then subjected to pretest probability, and each of them have been given a different weight. And if you want to know what the risk of infection is in each one of your patients, you should try to download this app, and in this app there is a risk calculator for infection. You'll put the metrics in, and the app will tell you what the percentage risk for development of infection may be. So let's start preoperatively. There are numerous factors, much like cardiovascular disease, that could result in infection. These may be divided into modifiable, non-modifiable, controlled, and uncontrolled. As you know, CDC published guidelines for prevention of surgical site infection. So did WHO. And this year, in July of 2018, we had the second international consensus meeting on periprosthetic joint infection, which included trauma and multiple other specialties. In this particular question was, what are the risk factors for periprosthetic joint infection and surgical site infection? High BMI, smoking, alcohol consumption, diabetes, malnutrition, and other medical comorbidities predispose patients to infection. Smoking has been shown beyond dispute to be associated with infection. As you can see, 94% agreement amongst delegates. Obesity increases the risk of infection, and this risk continues to surge rather than there being a real cutoff point. The risk continues to be higher in these patients. But the risk starts to rise rapidly after BMI of 40 kilogram per meter square. There's an association between hyperglycemia and uncontrolled diabetes. Hemoglobin A1C is not a great metric to determine glycemic control. We have written a paper on the use of fructosamine, which is available in majority of the hospitals, including in India. But there was 76% agreement that hyperglycemia is a risk factor, and the level for hemoglobin A1C, if you use that as a metric, should be around 7.5 to 8%, and not the 7% as outlined by American Diabetes Association. CDC recommends that the fasting glucose should be under 200 milligram per deciliter, and WHO also recommends intensive glycemic control in the perioperative period. How about opioids? Patients who take opioids, are they at increased risk? 71% agreement amongst delegates. Intra-articular injection by steroids, does that predispose patients to a risk? Possibly, but no one knows whether that risk goes away by waiting 3-6 months or some weeks. Infectious lesions in the skin, very important. They need to be treated prior to undergoing elective arthroplasty. Here we have 90% agreement. Malnutrition has been associated with periprosthetic joint infection and surgical site infection in other disciplines. Malnutrition is defined as albumin less than 3.5 gram, or other metrics such as transferrin, prealbumin, or lymphocyte count. but correcting the malnutrition is not known to be effective in prevention of infection. But nonetheless, malnourished patients should most likely be optimized prior to surgery. Again, 98% agreement here. Underweight patients are also at increased risk of SSI and PJI, and that's also critical to recognize these patients who may also be malnourished. Again, 92% agreement here. The story of HIV has changed. With the introduction of retroviral therapy, the risk for HIV patients now, as long as their viral count is 0, and as long as their CD4 count is greater than 500, it is pretty similar to the normal population. So HIV, not as much of a risk factor as it used to be. Again, 96% agreement. And patients with liver disease, in particular hepatitis, and particularly if that's uncontrolled, are at higher risk of SSI PJI, 98% agreement. And unfortunately, these patients also are at higher risk of bleeding because of platelet dysfunction. How about risk factors related to other disorders? It's been known in recent years that affective disorders such as depression and bipolar disorder and possibly anxiety also increase the risk of SSI and PJI, 88% agreement. Perioperative risk mitigation is very important. It is important for us to know what we could do in the operating room and afterwards to try to reduce that risk. How about screening patients for dental disorder? Although there is routine screening for dental disease is not recommended, patients who exhibit disorders of dental and oral condition should certainly be looked at and sent to a dentist and oral surgeon for optimization prior to surgery. We have a questionnaire that we administer at my institution, and 3 risk factors associated with oral disease is a patient who's not been to a dentist in the past year, patients who bleed when they brush their teeth, and patients who have had oral disease and multiple dental work in the past 2 years. So in this group of patients, we insist on getting dental clearance prior to surgery. The oral hygiene is very important in these patients, very important to make sure that that's optimized prior to doing elective arthroplasty in this patient population. Again, 92% agreement by the delegates. How about screening the patient for urinary tract infection? Again, no, your routine urinary screening is not recommended, but there are again some signs and symptoms of urinary tract infection, which includes urgency, incontinence, dysuria. And if these symptoms exist in the patient, then culture samples should be sent. And if patients have an evidence of urinary tract infection, that should certainly be treated prior to surgery. And this is usually 7 to 10 days of an oral antibiotic, re-screening the patient to make sure that urinary tract infection has been eliminated. This is acute urinary tract infection, but majority of our elderly females have chronic urinary tract infection. In this patient population, you might want to include an aminoglycoside as part of your perioperative antibiotics, and it may be safe to proceed with operating on these patients without having to put them through 7 to 10 days of oral antibiotics, because majority of chronic UTIs are not treatable by oral antibiotics. How about methicillin-resistant Staph aureus screening? I was part of the CDC guidelines. This was discussed for over 4 years. There is no conclusive evidence that screening for MRSA reduces the risk of infection. What is known is if you have a patient who is a carrier of MRSA, giving them the appropriate antibiotics is likely to make a difference to the incidence of infection. Because of that, currently we don't do routine screening, but if patients have had a prior history of MRSA, they're given vancomycin and dual antibiotics in addition. Fortunately, in recent years, agents have become available that are not antibiotic-based. As you know, mupirocin or Bactroban is not a great agent for MRSA decolonization. In recent years, iodine-based and chlorhexidine-based agents have become available with great efficacy, so it is possible that routine and universal decolonization may be the way to go forward. That may include decolonizing the healthcare workers in the operating room. It is one swab, 1 hour prior to surgery, and the effect lasts roughly about 76 to 90 hours. Again, 86% agreement. But the best method for MRSA decolonization still remains unknown. And that's why CDC made no recommendations about MRSA screening, and nor did WHO. How about patients who have inflammatory arthropathy and they're about to undergo surgery? This was taken up by American Academy of Hip and Knee Association, AHKS. Extensive work that's been published. This is obviously very, very extensive, very difficult for you to see, but it is available on that ICM Philly app. And that publication is also listed on that particular app. And it gives you the half-life of all the agents and when you need to stop those agents and for how long. How about skin cleansing? That was also discussed at the CDC. No difference between chlorhexidine-based or betadine-based agents, as long as alcohol is part of your preoperative skin prep. 92% agreement. Removing hair should be saved to the operating room or just before the operating room, and it should be done with clippers and not with blades. Soap or antiseptic agents are very effective, and it's very important that patients should have chlorhexidine-based soap or some form of wash prior to elective arthroplasty. Again, 91% agreement. Antibiotic prophylaxis, the best agent is still cefazolin because it has great bone penetration, great biological activity, but it should be dose-based. And in patients who are over 80 kilograms, the patient should receive 2 grams instead of 1. No the recommendations about dual antibiotics, but I think vancomycin should be given to patients who are MRSA carrier, institutionalized patients, those who are in dialysis unit, multiple hospital admissions, patients who've had prior history of MRSA, and in my opinion, healthcare workers. The timing should be within 1 hour. Don't look at that WHO guideline talking about 2 hours. That's too late. If you give it 2 hours before, there is not enough of the antibiotic in the serum to be available at the time of surgery. Local antibiotic delivery has been recommended against by CDC and others because of the fear of rise in antimicrobial resistance. Laminar flow, there is no agreement on what type of room you should operate in, but it's suffice to say that the room you operate in should have very good ventilation system with at least 500 cycles per minute. Forced air warming, nothing against the forced air warming. I know there have been some marketing and some hype in the media. It's not proven to cause any type of infection as far as we know. Again, 93% agreement by delegates. Ample evidence to support the use of a sterile povidone iodine. If you ask me what is one of the most important things I do for prevention of infection, it is why I administer povidone iodine to wound, leave it in for 3 minutes, and then wash it out. Again, that was also highlighted and recommended by WHO and CDC. Aqueous iodophore solution is very effective for prevention of periprosthetic joint infection and SSI. We use occlusive dressing. We leave it on for 7 to 10 days. We don't take it off, and this allows the patients to remain, the wound to remain silent and to heal. Risk mitigation may also include postoperative antibiotics. Usually we give it for 24 hours. Recent CDC recommendation talks about 1 dose, but I think we need further evidence before we can move into 1 dose instead of 24 hours. Oral antibiotics should not be given to patients after they are done with an uneventful total joint replacement. Anticoagulation, probably aspirin is the best. We'll talk about this tomorrow. I won't dwell on it too much. 80% agreement. Urinary tract infections, we talked about. No urinary catheters for patients unless they run into urinary retention. Management of draining wounds is a whole topic on its own, but if patient is still draining 7 days after surgery, they should be taken back to the operating room. So what do you do with all this information? We work together to try to improve the care of our patients. And
Your
again,
time is over.
the document is available on
Please
the
conclude.
ICMM. Thank you.